Over 2.5 million people have anterior knee pain or get treated for it, at least in the office. This is not an insignificant number, even over the age of 40 or 60, to be honest. And if you see this, we have knee arthritis affecting us every single day. We have to pay more and more attention to what people are telling us in the office. So we talked a little bit about how our implant can maybe help some of these issues. Reproducible transition zones have always really been a very, very difficult thing to literally reproduce each subsequent time. So we think we have a solution for that with our implant. And we talked about it's one of the only PFJs on the market that has a lateral resistance to subluxation, which we know is a tracking issue after patellofemoral replacement. So that being said, these are complex patients. Alex set the stage for this very nicely. These are complex patients in general. Are they isolated patellofemoral arthritis? Are they early arthritis? Are there malalignment issues? Where's the patella in relation to the patellar tendon? Prior surgery, obesity, age, all these factors should be coming into your head as you see these patients. So yes, do we start with all the conservative solutions? Most of you say we start and stop with the conservative solutions for a lot of these patients. Physical therapy, stretching, taping, bracing, I'm going to mention those, but let's be honest, in this healthcare world, there's not unlimited resources anymore. If we're utilizing physical therapy for osteoarthritis alone, that's going to be a challenging thing to reproduce and continue on. So pain management medications, nobody wants to go down that road. Cortisone injections, but I mentioned, in my experience, they seem not to work as well in isolated patellofemoral disease. So that's been my experience. I list hyaluronic acid, but just recently, in the last 2 months, several states are denying coverage for certain payers. So joint preserving solutions, there are surgeries that we can perform prior to a patellofemoral arthroplasty, right? And all these are listed here, and it looks like you have a laundry list of things to discuss with patients when you're in the office. But let's really get down to the nitty-gritty. A lateral release, most people are not doing those anymore, right? That does not stabilize the patella. In fact, it causes more destabilization than anything. And it may have a role in denervating, but it's certainly not a final solution for patellofemoral arthritis. And a lot of these other things, let's be honest, most of these are in the younger than the 40-year-old population. So we really don't have all that many solutions. So you look at this big algorithm, and we have conservative solutions way on the left and joint preservation solutions in the middle. There may be a direct line from those conservative things right to PFJ, or even for some surgeons, total knee. And there's not a lot in the middle. So I'd encourage all of us to kind of continue to think about those things in the future. So let's talk about this in general. 49-year-old female. So left knee pain for 10 years. X-rays, MRI, CT scan. I list all those. Those are not necessities, but and I'm not going to tell you what I do every single time, but I'd like you to consider those things in your evaluation. So X-rays, I think, are essential, but we'll talk about what are the classic things that we're looking for. So here's what I talk about. Merchant view of the X-ray, right? It's a great view. It tells you a little bit about subluxation. People are in a little bit of flexion during that. But it's kind of dependent on the quality of the image. If that beam is not going the right direction, it can certainly overestimate patellofemoral arthritis. And I think there should be a recurring theme here, which is treat the patient, not the X-ray or imaging studies, especially in this incidence. So the lateral view, certainly Alta versus Baja is important. I think in many ways the lateral view for me for patellofemoral could be the most important. If it's a good X-ray, you can find out if there's shallow trochlea, if there's hypoplasia. So that's very valuable. And obviously, we have to talk about a little bit of a TTTG, which is the tibial tubercle trochlear groove measurement that's become very, very popular. And that can be done on CT scan or MRI very reliably. How important is that in this person, the 49-year-old, versus 25 or versus 16-year-old? I think it's still important. I think we need to know if there's a significant lateral force vector or rotation on the patella, because that will dictate the success of the patellofemoral arthroplasty later. What else do I look at? So MRI. Most of these people are getting MRIs. I think I'd be crazy to tell you that I'm trying to skip that step. A couple reasons. You can tell a lot about the patellofemoral region, the cartilage injury and thickness. I'm not fantastic at it, but I think it's a hard area to examine. However, it probably tells you if there's other concomitant injuries. The last thing we want to do, and Alex said it nicely, is the last thing we want to do is tell people we're going to do a patellofemoral replacement and miss a lateral compartment injury that causes pain, and now we have a situation where they have pain and we're revising because of pain when the patellofemoral replacement functioned quite well. More of historical significance more than anything else, but I will tell you that I've done it. I made that name up. I think in my training we talked about this, which is a dynamic CT scan. Which you can do in 0, 20, 60, 90 degrees, which tells you more than anything where that kneecap is in flexion at different degrees of flexion. And that does help me sometimes, to be honest, sometimes postoperatively or sometimes preoperatively. And it's an analysis of tracking. So let's get to indications of these people. So age, does age play a major role? Well, in your head and in their head, you have to think, is this their last operation? You're not going to be able to answer that question, but you need to ask that question of yourself. And could they maximize their function with a total knee arthroplasty? Good article about 7 or 8 years ago in the Blue Journal that finally said with today's patellofemoral replacements that they did better at the 2 or 3 year mark than a total knee replacement, because for many years we were saying maybe that's the other direction. But that may not help us because 2 or 3 years is not long enough. And Alex even said that 10 years, is that acceptable? And all these other factors. Well, I think we have to make that decision on our own. So I don't do many of these in the 60 or 70-year-olds. Are there patients with isolated patellofemoral arthritis? Absolutely, and that's certainly a great indication, but I'm just telling you in my clinic, in my experience, that's what we have. Less than 40, we're going to reach for a biologic alternative. I think that is where I'm going to go in most of the time. So most of my PFJs are usually between 40 and 55. Just BMI, I mentioned a couple factors that I think is awfully valuable. So BMI in general, there's been a lot of talk about that, whether people should be denied total joint arthroplasty, if you looked at recent Orthopedics Today. Higher weight, less favorable than lower weight. That's not a shock, but for partial knee arthroplasty especially, we have to be careful. There's other areas that are loading with these people, and they have a much higher incidence of pain in other parts of the knee. So this has a definite potential to bias your results, and I would caution people about that. Because again, we've said it already, should be echoed, revision or conversion for continued pain, that's not necessarily a great solution. So gender. Many of these are female. I think we all know that. There's a Q angle, there's a valgus knee, there's a lateral force vector on the patellofemoral joint. The males, they do exist. They're usually limited to post-traumatic, and I'm kind of quoting anecdotal things. So I put all these slides together before I did this slide because I wanted to test myself a little bit and say, what's my last 20 over the last couple years? And that's really what it turned out to be. So getting back to our 49-year-old female, the discussion in the office has to be a couple things. Quality of life. What is she doing now that she can't do, or can she function? Because you really would like somebody to go for as long with their own knee as possible. Functional return expectations. What's her job? What she want to do afterwards? If it's climb Mount Everest, that's not okay. And alternatives. And this is all part of the process that I think is becoming more and more popular, shared decision making, and certainly many people are talking about it, but Kevin Bozick is championing it, which it basically says, let's take the data we have from outcomes and apply it in a way that we can apply it to patients. And so we have some data. Luckily, there's a registry, SOS, and it's doing well. You can see the numbers are not significant for patellofemoral, but they probably shouldn't be with the number of patients. I think Most of these are mine, so if you compared it to the global data, I think it's the same. But we have all the trends that we want to see, right? So in VAS, WOMAC, and OKS, we're all trending in the right direction. I know it's not ready to talk about future things yet. So if we go back to the continuum of care, we are going from conservative to iBalance PFJ in certain patient populations pretty quickly, I would say. And I would still venture that that's better than somebody having a total knee replacement. So bi-compartment replacement, I just wanted to touch on this very quickly, a couple quick slides. It's an idea, it's a concept. These are people that have bi-compartment disease or tri-compartment disease with less lateral disease, but they're not painful there. Typically, those people are under 55, usually 30s or 40s. They have a trash knee. They've failed all conservative things. They've had multiple previous operations. So what's my experience? I've done 2 bilateral cases. I talk about a bridge procedure. And Dr. Cohen talks about the bone-sparing technique that the total knee gives for us. All these are very bone-sparing techniques, and I think that has to be thought about when you're thinking about these. And then use the Oxford data about patellofemoral replacement and say, don't treat the images, treat the symptoms. So if they truly have patellofemoral symptoms, it's an option, but these do not function like a uni. So our case, she is opting for a patellofemoral replacement. We're going to do an outpatient case. She's back to most activities in 6 or 8 weeks, 3 months for strengthening. And I use this term all the time, better than when you came in at 4 to 6 weeks. And how do I know that? Because we have the SOS data from knee arthroplasty that helps us.